We're now going to hear from our stakeholders. And what we'll be exploring today is how do they see their responsibility in creating value for all patients? Can a balance be found between innovation and cost sharing that does not impact some of the consumers adversely? We're also dabbling in interior design, so bear with us a bit while we redo the stage here. But we have an exciting panel coming up here shortly. It's been an exciting day here, am I right? So now that everything's set up, without further ado, I'd like you all to help me welcome on stage Lisa Holdersma. She's the Senior Vice President of Policy and Research at Pharma. Eleanor Hiller, partner at Alston Bird, a former senior advisor to the CMS Administrator. Laurie Fenton Ambrose, co-founder, president, and CEO of Go2 Foundation for Lung Cancer. And Dr. Mark Fendrick, director at the University of Michigan Center for Value-Based Insurance Design. Give them a warm welcome, please.
Everyone, it's already been such an exciting morning here. I was just ushered downstairs, so being rushed back up, trying to get my bearings straight. And I think we're waiting on two of the panelists. We were ushered downstairs quickly, so I'll just basically give an overview of what we'll be talking about. Basically, Medicare Part D and the rising costs. Why are costs rising, and why are seniors having some issues in some cases accessing these drugs and these innovative technologies? So, I'll just start with a general question to you two. What are the challenges, the primary challenges Medicare beneficiaries are facing when it comes to out-of-pocket costs in particular? And from both of your perspectives, what's the crux of that problem? Lisa, I'll start with you.
Sure. Great question. Thank you for having me today, and thank you for that question. I think, when you look at Medicare Part D, this is a program that has been wildly successful by many measures. And one thing that we frequently talk about is the fact that premiums have been very low in Medicare Part D and have been stable all, in recent years. And, I think as we have watched the benefit evolve and as we have seen new medicines come to market, what we have observed is that there has been such a premium, if you will, on keeping premiums low, that we are now seeing plans essentially asking patients to pay a higher share of out-of-pocket costs. And there's kind of a direct correlation between premium and out-of-pocket costs. And so in Medicare Part D, what we have seen, again, flat premiums, but really an explosion in the coinsurance that beneficiaries are expected to pay for drugs. And of course, in Part D, sort of uniquely in the insurance market today, beneficiaries do not have true catastrophic protection either. So what we are seeing is for the sickest beneficiaries, really, an uncapped liability under this program, and that's, affecting a lot of patients.
Yes, and I'm actually just going to introduce our two other panelists who also have been brought up from the false alarm. We have Laurie Fenton Ambrose and Eleanor Hiller. So great to see you both here.
Thank you.
Apologies for that interruption. It's been a very fun morning here. Dr. Fendrick, on that same question we were just talking about, to catch you guys up, the challenges Medicare beneficiaries are facing when it comes to out-of-pocket costs. Can you speak more to that? And also talk to us about value-based design, something you have had such an integral part in developing.
Well, thank you all for having me, and I'm wondering why I wasn't ushered out.
The whole audience could point.
Actually, now that you say that.
So to follow on Lisa's comments, so I'm a practicing primary care physician. I see these issues about out-of-pocket costs every day, and I think my most tweetable soundbite, since most of the audience is often tweeters, is that Americans don't care about drug costs. They care about what it costs them. And all this discussion in this town about drug prices has failed to distinguish between what my patients pay out of pocket and what the price of various services are. And as Lisa said, we've made people pay more for all services, high and low, for the lack of a nuanced benefit design. And people are just going without those services that I beg them to do. This is particularly important in the drug space, and even more important in the Medicare space, where more and more people live on fixed incomes. And I'm so impressed by the Federal Reserve report that says that 40% of Americans don't have $400 in the bank. And if you look at the rising deductibles and co-payments and co-insurance for the drugs I beg my patients to do, and many clinicians are benchmarked on, we have to have a better way. And value-based insurance design is hopefully an intuitive concept that instead of setting cost sharing equally on all services, all visits, and most importantly, all drugs within a tier of a prescription formulary, the VBID concept sets cost sharing based on the clinical value of the service as opposed to the price. So we've seen this across the country and in Medicare and preventive care services, where beneficiaries often have to pay nothing for preventive services, but we've not been able to pull that through in the Medicare Part D program outside of the value-based insurance design demonstration. Fortunately, there is a part of federal legislation that mandates that first dollar coverage or full coverage for patients for U.S. Preventive Services Task Force D-rated services. Very few of those are in that list, but you might have heard about pre-exposure prophylaxis for HIV was just mandated as a fully covered service by the U.S. Preventive Services Task Force, suggesting that there is a movement afoot to create these nuanced benefit designs that will improve access to those really strongly evidence-based services and leave it up to Americans to pay their own money for the services for which the evidence is weak, and most importantly, save for the several hundred billions of dollars that we buy in the Medicare program for things I wouldn't buy even if they were free. So I'd rather see cost sharing on those services trade off with much lower cost sharing on those high-value drugs in the D program.
Lori, you advocate on behalf of patients. What are patients saying about the current status of Medicare, and what are the challenges they are facing with rising costs and maybe having trouble accessing some of these drugs, therapies, et cetera?
Yeah, it's such an important question because, again, echoing Mark's comments, it really isn't about the price of the drug, it is what people can access and afford, and how do we make that a better system for them. We have a helpline. We receive hundreds of calls a week, thousands a month, and more every year. The top question, second only to learning how to manage a diagnosis, is I need financial assistance. So just because you have insurance doesn't mean you can avoid financial toxicity. It is real, it is present, and we have to be able to figure out a way, which we were talking about earlier, to think about making sure that the right medicine is getting to the right people at the right time without a third party intervening in that process. And I think that may be a better way of trying to reformat a system, because we are in this era of a more personalized, individualized endeavor. And that's what we have to make sure the system isn't a one-size-fits-all for. But it is real, and no one should have to choose between whether or not they buy food or clothing or medicine.
And Eleanor, you have more perspective on this from maybe more of a government perspective. So you came from CMS not too long ago. Could you speak to that and how the government is working to combat these issues and their role in all of this?
Sure. So I think there are some themes that have been consistent for a while. You know, this drive towards value and making sure that patients in the system can get value out of the Part D program to make sure that it's working for them to get drugs that they need. There have been proposals that this administration has carried forward that have been along for a while. I think we've seen some interest even recently on the Hill related to restructuring the catastrophic phase of the Part D benefit at the same time that CMS has a demonstration project starting in 2020 that would do just that for plans that want to participate, you know, alongside the VBID demonstration that's there as well, that includes some important flexibilities, particularly in the demonstration related to Part D. I think the current administration puts a particular emphasis on consumer empowerment tools and making sure that the beneficiaries are not surprised when they get to the pharmacy counter. So the emphasis on real-time benefit information, potentially even at the time of the prescription being written, so that we're taking advantage of technology to get information to the point where it can be useful for the patient, I think has been a big focus of this administration's particular take on what it means to get towards value and how the patient themselves can be part of that equation.
So as while we're on the topic of the administration and the role of government in this, we have seen recent restructuring proposals for Medicare Part D in Congress that have come up. And, you know, I think we're going to keep on hearing about this as Congress goes on and even potentially on the 2020 campaign trail. But I want to hear what you all think of the Medicare Part D restructuring proposals. Lisa, can I start with you on this?
Sure. Well, I think, you know, the only thing that we've seen actually in writing so far out of the Hill is the draft legislation that the Ways and Means and Energy and Commerce Committee released for comment, and that included restructuring the plan and government liability above the catastrophic, and then also creating that hard out-of-pocket cap for beneficiaries. And, you know, pharma is supportive of that concept. We think the out-of-pocket protection is critical. We actually did engage prior to there being a legislative opportunity, hoping that the administration perhaps would at least try to put an out-of-pocket cap on D expenses within the Medicare Advantage program. Obviously, if you're doing it across the board in the standalone plans and Medicare Advantage, that's far better for patients, and we are supportive of that.
Dr. Fendrick, I know you've come at this from more of a bipartisan academic perspective. Can I just get your thoughts on these proposals?
I want to build on Lori's comment about how we need to move away from a one-size-fits-all system. And I wish there were more clinicians actually involved in these policy changes, because I hear when clinicians actually become members of Congress, they forget everything they know about clinical medicine. So the idea that we would have a benefit design that's equally accessible or inaccessible for a drug that I beg my patient to take and a drug that I beg my patient not to take is the real change that we need to make. I think that if you look at all these policies, the amount of money that my Medicare beneficiaries pay out of pocket is independent of the clinical importance of those things. So I'm hoping that we could extend the wildly popular idea of making high-value preventive services no cost, to extend them to the highest value preventive services I have, which are to medications to manage people who are newly diagnosed with a condition. So the idea that we would have these changes of whether it remains to be 25% of what the beneficiary would pay or what the catastrophic aspect would be has to be tailored to the clinical situation, which is why I'm so enthusiastic about the value-based insurance design Medicare Advantage demonstration, which is one of the few demonstrations that was started by a Democratic administration and actually expanded by the Republican administration, showing the kind of the political fortitude of the importance of lowering out-of-pocket cost for high-value clinician visits and services. And there are already Medicare Advantage plans that say, in these patients with specific conditions, regardless of the drug being a brand or generic, because it is so high value, I could reduce the out-of-pocket cost for you. And in the first 50 years of Medicare, because of the uniformity rule, you couldn't lower cost sharing for a particular person because they had a particular disease. Now we could do that in the Medicare Advantage demonstration, and we're even going further in the fact that you could tailor these cost sharing reductions for people not only based on their clinical condition, but also their financial situation, because you know, the people who need cost sharing relief the most are those who are financially insecure and those with chronic diseases. And unfortunately, that is a significant proportion of the Medicare population.
And Lori, no doubt these restructuring proposals would impact patients greatly. Walk us through how patients would be impacted and what that process would really look like if Medicare Part D were to be changed that much.
Well, again, and keying off of some very important thoughts that Mark and certainly Lisa have shared, it is about trying to ensure the system is agile and adaptive to what the patient's needs and circumstances are dictating. Because again, the term value, again, it means things. It means different things to different people, and we have to be very careful how we think about that word value. And not disadvantage those because of an age a terminal illness or a disability. At the end of the day, we have to keep thinking about people at the hub and how we structure a system accordingly around that. If we can move things to earlier understandings, earlier detections, earlier interventions, management, you can actually improve outcomes, survivorship, quality of life, which prevents these more expensive downstream late-stage management situations that we currently have. So again, to Mark's point, how do we look at changing a system to these earlier opportunities that can actually and target those appropriately and that are valued by patients, and using real-world experiences in that process, patient registries that are capturing this information that can help inform. That is one of the ways that I think we're going to be able to help find resources in the system to support the extraordinary innovation that our country is driving for the world.
Right. And Eleanor, this is a very broad question, but to piggyback off of the one I just asked, what does this look like from the CMS perspective, the government perspective? I mean, clearly this is a huge undertaking to restructure this program that was started essentially just, in 2003. So it would definitely take, I would assume, quite a bit of manpower and such.
Well, I think, the Part D program isn't that old, and yet there's been a real significant change in the way drug spending looks. So, I think there's been a six-fold increase in catastrophic portion of the Part D spending over the last decade, I think. So, to take a look at how the program was structured very intentionally and what it may need to look like today, I think that's why you've seen this focus in President's budgets over the last 4 years at least, and now on the Hill as well. I think there's a lot of work in Part D that happens not just at CMS, but on the plan side as well, as they figure out how to take advantage of opportunities to be more engaged in management throughout the benefit. I think you'll see the goal of some of these proposals is to incent behavior, not necessarily on CMS's side, but in the outside from the plans that are managing the benefit. CMS does a ton of work. There's a ton of work that has to happen every single year. But I think whether changes are of this magnitude in terms of what the effect will be for plans or smaller, it's still just the staff work of going every year through a regulatory cycle and getting things out the door.
I want to talk more about innovation and the access that patients, and in particular, obviously Medicare Part D recipients, can get to these new innovative therapies. I'll start with you, Lori. Is cost the reason why there seems to be this struggle for them to access these therapies and these new drugs?
It's more systemic than that, because it can involve the access to primary care doctors that can guide a multidisciplinary team that is knowledgeable and can manage in a holistic way where you live and how close you may be to a hospital center, all the complications that can arise from not just being diagnosed, but figuring out how to manage your care. So of course, cost is a huge factor in whether or not you have the appropriate coverage, but you also have the access to the care that can best guide that process. So it's multifaceted. And just addressing the cost of drugs is not going to necessarily fix the problem. So we know for the lung cancer community, which we represent, just in 2008 alone, we had 8 new drugs come on the market. And we're seeing some of the most revolutionary research and breakthroughs occurring that are allowing for more targeted therapies and, frankly, triggering our own immune system to do what it is there to do, and that is fight disease. So these are extraordinary times, and of course it takes resources to bring that forward. But then we have to look at how we adapt those resources to the benefit of the people who will be receiving that care. And so the issue is, again, it's not so much price, but it is what it means to get it to people in an affordable and accessible way. And that's what we have to keep digging away and peeling the layers back and thinking about new strategies and focuses.
Dr. Fendrick, I see you nodding over
You know,
there.
I only allow myself to come to Washington every other week because, because when we talk about healthcare in this town, we talk about money. We don't talk about health, and it's so refreshing to hear your perspective. To think about in the 25 years I've been practicing medicine, it's just mind-boggling the innovations that have occurred that you spoke about. I call that Star Wars science, and it's even getting better moving forward. The problem is that we're currently in Flintstones delivery, and we need to, most of you people don't know who Fred Flintstone is, but ask your parents. We need to bring Fred Flintstone to the space age, and one of the ways to do that is to understand, which is one of the few things people agree about in this town, is there's more than enough money in the healthcare system. Everyone agrees that there's more than enough money there. We're just spending it in the wrong places. And if we could follow Lori's lead and say, let's spend the money not on the services that are most accessible or most profitable, but start spending the money on the things that help our patients the most, we would all be better off. And that means not only improving access to the evidence-based services for which we know help patients, we have to have the courage to identify, measure, and reduce the services that we're buying that are not making Americans any healthier. We are lucky enough, or unlucky enough, depending on how you look at it, to have enough money that I would call headroom, that if we would get rid of the services that, no matter what the price, that don't make Americans healthier, we could fund almost all, at least, of the shortcomings of the high-value services that we've identified that are markedly underused, not only for the reasons of cost, but cost is at least something that we could certainly address. And we know, as my mother says, if you make people pay less for something, they will certainly buy more of it. And the evidence from preventive care would prove that to be true.
And we do have a short period of time, about 4.5 minutes for an audience Q&A. So if anyone has any questions, now is the time to ask them. So if you're still thinking about them, I'll give you some time to think about them. Let's talk about how to deal with catastrophic coverage limits, and essentially what's what in your opinion, your all's opinion, is the best way to deal with the rate of enrollees reaching that catastrophic coverage limit. We'll start with you, Eleanor.
Well, I think there have been a lot of changes to the Part D benefit structure even over the last few years, where the beneficiaries are seeing a slightly different experience as they walk through, both with respect to changes that stem from the ACA and took a decade to implement, over time as was intended, and more recent changes as well. So the beneficiary experience is already starting to shift. I think in the catastrophic side, some of it just is very specific to an individual's experience and what drugs that they're on.
And Lisa, could you speak to that from pharma's perspective or corporate perspective?
Sure. Well, I think that probably the most important thing that could be done overnight, virtually, would be for the administration to finalize the proposed rule regarding the use of rebates in Medicare Part D. I mean, beneficiaries hit the catastrophic because of what they have spent pre-catastrophic. So if we can reform the system in a way that what beneficiaries pay is tied to what plans and PBMs are actually paying for the drugs, as opposed to the undiscounted list price, which is what is happening today, we are going to slow beneficiary spending and ideally reduce the number of patients who are going to hit that catastrophic. There are other things as well, but that would be the first thing I would do.
Great. And the last call, we have a little over 2 minutes left. If anyone has a question from the audience, now is the time. And if not, oh, yes.
Can you give us some examples of the type
There's a microphone coming right there.
Could you give us some examples of the type of health care that you think is wasteful and should be gotten rid of?
Sure. I'm happy to identify the things that we could get rid of. So the first point is that there's no medical service ever that's always high value and low value. It's a nuanced situation. But we have focused on bringing together active purchasers to get some energy around the reduction of low value care. You could find our work on the web on the Task Force for Low Value Care. I wanted to call it the Waste Task Force, but WTF was taken. So I'll list you the top 5, or the ones that I could remember. So first off is population-based screening for vitamin D testing. I would imagine that many healthy women in this room have received that test, or even I see some nods. They don't even know they had it. They were never told the results, and there's nothing you would do if you had that. So vitamin D is kind of my stake in the ground. We have imaging for non-urgent musculoskeletal back pain that doesn't have red flags, CT scans and MRIs. A very costly one to the Medicare program is preoperative testing for low-risk patients before low-risk surgery like cataracts. 90% of people who don't need lab tests and EKGs get them just because. Same holds true for PSA testing for men over the age of 70. The U.S. Preventive Services Task Force says that this is not only something that should be discussed, it is dangerous in certain populations. So all the U.S. Preventive Services Task Force D-rated services, I think, should be addressed. And there's a very small part of the ACA that I think only 4 people have read. Eleanor is one of them. Section 4105 that gives the secretary the authority to not pay for D-rated services. Oh, that's not been enacted upon. And I think another really easy one, since we're talking about Part D, is specifically those branded drugs that are used in the setting of an equivalent generic. So this is not therapeutic equivalence. This is a branded drug and the generic drug are exactly the same. And there are estimates still that billions of dollars are being spent on this. And I can't speak for pharma, big P, where Lisa sits, but I've worked with many, many pharmaceutical companies that are very happy to give up their marketing and patient assistance programs for this very small part of the pharmaceutical sector if there would be more of an opening or empathy toward the patients that Lori represents who have to have a bake sale or start a Kickstarter campaign to get a drug that was designed for her. So the only way I see move forward to be able to pay for that cancer kill 'em all, the exciting drugs that we see as clinicians moving forward that are expensive, is to have that courage to identify and eliminate low-value care to create this headroom for us to be able to buy those things that we know will help the lives of Medicare beneficiaries.
I think that's all the time we have. Thank you all so much for such a fascinating, informative discussion and for bearing with all of us during the fire alarm or whatever it was. We're all okay. Thank you again.